I hope that I have mentioned the name right, from Saudi Arabia. Mr. Erik is a nurse leader who is affiliated with Sultan bin Abdulaziz Humanitarian City in Riyadh. He had his Bachelor of Science degree in nursing in 2006 and finishing of his Master of Arts degree in nursing administration and leadership from Philippine Women's University. I am passing him the stage to deliver the speech. Welcome, Mr. Erik.
Yes, thank you very much. Just to say thank you to the UCG and to the rest of my colleagues here who have participated and currently is present in this conference. It is a privilege for me and a pleasure to present to you
The
one
pleasure is
success.
mine.
Yeah, uh, a success story of which maybe we can learn something from and we can progress with this particular story as well. I will be sharing my screen with you. Can you see my screen? I'm sorry, Miss Amal, I cannot hear you, please. Is my
Okay,
screen?
yeah, I can see your screen, but we would ask for you to.
I think there is a problem with the connection. But anyhow, if I'm clear, let me start this with presenting to you as to what Miss Lina Ubaid, one of the keynote speakers in the morning session, had mentioned to you that we came from Sultan bin Abdulaziz Humanitarian City. It is a big hospital in Riyadh, Saudi Arabia. And we are currently employed here. And thus, this success story, particular success story, happened. These were some pictures of our institution. Yes, we are a 500 plus bed capacity hospital that is most of a rehabilitation facility and a medical center. It's situated in just north of Riyadh and about more than 1 square kilometer in size. If we talk about the campus in its size and location. We are accredited by various organizations, Joint Commission International. We have CARF, the Commission on Accreditation on Rehab Facilities, SBAHI, ISO, Ottawa College of American Pathology, and Center for Excellence for Bariatric Surgery, as well as we are working on our plane tree as well. So our department, Nursing Services Department, in the onset of the pandemic, had already visioned that what about if we will be receiving patients who are COVID-19? We visioned and we worked on a plan to make sure that we are competent and ready enough to receive patients, may it be referral from the government or patients just coming in because of the pandemic, or we will be having our own outbreak of ourselves. So we aim to replicate, if not exceed, our excellence in rehabilitation nursing, as our primary service is really rehabilitation, and thus we want to progress and we want to excel as well, or exceed the excellence that we are showing in rehabilitation nursing to COVID-19 patients as well, but in a safe and secure environment. So what we did was we need to ensure that we field nurses who volunteered to be part of the COVID-19 team. It's very essential and a very key point that we must understand that these are volunteers who selflessly devote their time and their effort in order for them to take part in this endeavor. We ensure that they are confident to care with the competence and updated knowledge and skills. We made sure as well that there is an available PPE and all other equipments and consumables that they will be needing. It is a 24-hour, 7-day service every week. And then we made sure about this nursing model of care, COVID-19 specific one. Sultan bin Abdulaziz Humanitarian City, its nursing services, as I mentioned, has this specific volunteers, 72 strong nursing team. I have I'm leading the team as a nursing service manager, and I have 2 head nurses with me. There are 42 inpatient staff nurses, nursing assistants, ICU nurses, ER nurses, paramedic, and ATS. We also define the care areas. We have cohort system wherein we have dedicated inpatient units to take care of the positive symptomatic patients. If need be, we have a dedicated COVID-19 ICU We also have quarantine locations for those patients who are positive yet asymptomatic, uh, not to put or place the burden or the work in the inpatient unit. So there is a separate quarantine location of three. It's a three-story building with roughly around 140 beds in capacity to isolate these patients. Also, we are catering this. We did cater for patients for monitoring for those that are waiting for PCR swab result that cannot isolate themselves at home. We also did the screening and the visual triaging. And as I have mentioned, we added negative pressure rooms and stuff like that. But also one important thing is that we have a dedicated staff accommodation that we can isolate our staff, our own COVID-19 team, so that they can be separated from the rest of the city or the hospital staff. So what is a model of care? Model of care, it is what defines the way health services are delivered. It outlines best practice care and services for a person or a group, excuse me, for a while, for services for a person, population, group, or cohort as they progress through the stages of condition, injury, or event. It aims to ensure people or the patients get the right care at the right time by the right team and in the right place, of course. So, in considering things that we consider in our development of the model of care are as follows. The availability of the resources. We know that it's pandemic and we may have certainly face a challenge with procurement of needed consumables and PPEs, but we our leadership and the organization made sure that aside from the PPEs and the needed equipment, we have the space as well that is ready to take care of these patients. We utilize cohorting of COVID-19 patients instead of just localizing them per negative pressure rooms. We also had followed the MOH or the Wikaya guidelines from the Ministry of Health of Saudi Arabia. Also, we have from CDC and the WHO updates. We also referred to the publication of research studies and the practices that are being practiced at that particular time in countries all around the world. We also have to ensure that we take into consideration specialized patient needs. We are a rehab facility, major service is rehab, so we need to make sure that we might be able to receive patients of such nature. So age and rehab program specific conditions are also taken into account. Also, the presence of disabilities. There might be COVID-19 patients who may present to us with disabilities. Along with that is the staffing and scheduling. Okay, so number of nurses are required. How many are those that we require? Duty hours. Will it be 4? Will it be 6? Will it be every 8 or 12 hours? So we studied everything and we took into account the first we implemented 6, then we are now into 8 hours. So during COVID-19 pandemic time in the highest peak of it, we have an 8-hour shift but we really ensured that there will be 24 hours of rest in between those shifts for all of our nurses that involves in the direct patient care. We also made sure that the accommodation is available, also the food and other provisions, other necessities for our COVID-19 team, because they will be isolated from the rest of the city workforce. They will be only catering COVID-19. This is to ensure as well that we will not be the transmitting infection if we do have as carriers, because a lot during that particular time, a lot is still unknown about the disease. And then the nursing equity tool, which is one of the highlight of the whole model of care. The nursing equity tool I will be discussing later. But it is a part of the whole concept of this SBAHC, or the Sultan bin Abdulaziz Humanitarian City nursing model of care. We want to make sure that we render the best patient experience in the city, as what we call Sultan bin Abdulaziz Humanitarian City, through giving high quality, safe, efficient, and empathetic nursing care, taking into account the infection transmission risks and the length of exposure for both patient and nurse. Nursing actions are focused to promote overall health of the client. is not only treating the signs and symptoms of COVID-19, but also lessening its impact to patient's function en route to improving patient outcomes in rehabilitation. So along with these key points are as follows: the best patient experience. We have to make sure that we are following the guidance for the correct COVID-19 care. We have the concept and integrated it in the rehabilitation nursing into our care plans. We have to make sure that we have delivery of safe and high quality care, because we need to make sure that uh, even though the patient is in isolation, we are still giving the quality care that he or she deserved. Infection prevention and control measures and filters were adhered to. We have established a body system in donning and doffing of our PPEs. We cohorted dedicated care areas, and we have the anti-room. We're in a 24-hour coverage. It means to say, along with the dedicated care areas, is that all provisions, may it be food for the patients, linens, fresh linens, or medications, uh, all of the things that are necessary yet can be kept away from the care areas are being supplied by the anteroom on a daily basis and when necessary. So it's a 24-hour coverage manned by our competent nurse assistants. We also have shower rooms and laundry services for patients and staff. Lessening the impact of COVID-19 means optimizing patient outcomes. So an example of this is mobilizing patients, giving them the exercises for the range of motion, so that we can prevent the development of HOs. So that is just but one example. Isolation of COVID-19 team, this is also, as what I've mentioned, is important. We have made sure that we provide them with their needed accommodation, with the food, other necessities, even internet. We have provided it to them. We also added more negative pressure rooms and HEPA filters. As I mentioned, even if it's so redundant, availability of PPEs. We have hospital to hospital and and the Ministry of Health referral system, wherein we can directly transfer patients who need, for example, ECMO. A patient who needing ECMO, we can contact the Ministry of Health, and then put into their priority list our patients. But this we can also transfer to a specialized hospital, the Prince Mohammed Hospital, wherein they're catering for those infectious diseases cases. We also made sure that the waste management is also catering for this, is also being adhered to, as well as up to the standards wherein we can be able to ensure everybody that we are taking care of our waste. Our enhanced contact tracing, when our own outbreak occurred in our own facility. I will be discussing that as well later. We had readied a backup list of staff whenever it's necessary. Aside from those that were activated, we have a backup list of volunteers as well. And we made the diagnostics accessible, x-rays, lab works, all of that. We made sure that as part of our team, they are also COVID dedicated staff. So even portable x-rays are being are catered in the care areas, as well as lab works, the ESRs, those CRPs, those blood investigations that are needed in the COVID-19 care. Our own efforts to flatten the curve. In the early onset of our efforts in this pandemic, we were following the MERS-CoV guidelines. This is well known all across Saudi Arabia, as we have limited epidemiologic data of the disease. We also have followed visual triaging, and not only this, these are just some of those that were relayed to us by the Ministry of Health in their own circulars. We have managed the management of our own internal outbreak, wherein we had enhanced 3-clustered contact tracing, meaning the index and his contacts will be in the first cluster. Then we will be also assessing as well the contacts of the first contacts, meaning that will be the second cluster. And then calling again those that are contacts of the second cluster contacts, wherein if they are symptomatic, we will also be calling them, monitoring them, and along those lines of traces, we will we made PCR swabs and just make sure that everybody is safe. just to halten to stop and stop the spread of the infection. The provision of PPEs, I know it has been long since ruled that we will only be needing for what do you call it, the precaution. It's not airborne, it's droplet precaution. But our institution made sure that the care providers are safe and added hazmat suits into our PPEs, also N95s and the face shields and stuff like that. So we were facing the battle complete and ready. Kudos to the administration and the leadership of this organization. Also, updated and daily guidance from the Ministry of Health. So we have our dedicated IPC team and the physicians, the infectious disease consultants, who are keep on monitoring our compliance with this. And also, Ministry of Health has been sending their own staff to monitor us. Sustaining this, we have our own screening stations and telehealth nursing. Apologies for the spelling. Telehealth nursing, wherein we are calling patients and monitoring them. If need be, we will be sending our own nurses there to, especially those in quarantine facility within the campus, monitoring them and relaying the results to the physicians. We have intensified education, advertise all of the needed measures in order for the all of the people, all of the employees and the staff, clinicals or not clinicals, to be to understand what COVID-19 is. Also, the IPC control team and their hot and cold zone activities, meaning they divided the tasks between hot zone, meaning those are direct contact to the patients. Cold zones would be the one who took over the contact tracing from us during the onset. So cold zones, all of these activities are thankfully being carried over by IPC team up until this day. The screening stations and triaging, as I've mentioned, we have lean documentation, our own HIS system or the inter-system. As I mentioned, we are a rehabilitation facility. Our main service is. So more of our documentation, we're leaning towards making sure that it is appropriate for rehabilitation, like the functional measures, all of those stuff. Toileting, we have all of the documentation in our care plan. Previously, we're focusing on them. But during this particular time, we made sure that we leaned out those documentation and still adhering to all the standards of the accreditation and the governing bodies, leaning those out to make sure that we will only be limiting the documentation, but essentials are there, and those that are needed are there, making sure that it is just that the appropriate documentation for our staff to focus on the task at hand. Also, I've mentioned the Acuity tool of nursing, and also the support and recognition for the frontliners by the management. They provide us with psychology support, psychologists, and the people experience department. We're calling us during our isolation and making sure that we are upbeat and we are really feeling we are not stressed during that particular time. It also helps that we have in between 24 hours of rest in between the shift at least. So the nursing acuity tool, as what I've mentioned, is one of the highlights of this model of care. What is the purpose of this? The acuity tool, as what our colleague just mentioned in the previous presentation, it defines the number of competent nurses required for each shift in relation to the number and severity of COVID-19 patients. It ensures fair distribution of workload amongst nurses on shift to empathetically care for COVID-19 patients. Meaning, with this use of the acuity tool, we are able to predict how is the workload. We can define how many staff we are going to activate or send on shift, and then divide the workload among them. Also, because the goal here is to make sure that all of our patients will recover, that no one in our front lines will acquire the infection. Concept is simple. We have to efficiently deliver safe, high quality, and empathetic nursing care to every patient at the right time by utilizing the resources appropriately. If it need to have a more resources, need to activate more staff, then we will do. This is the concept and why we had the acuity tool. Patient care provision in the most efficient manner and lessen each time of exposure. We believe at that particular time, and even up to this date, that if we limit the exposure while rendering appropriate and empathetic and high quality care to each patient, we are also lessening the chances of infection. We only have activated the right number of fully competent nurses. This is a picture of what our Acuity tool was. So with regards to this, you might be able not to clearly see, but it is a tool for us to depict what are the necessary activities that we are entailed to do, providing the care to our patients. So this will give us a summary at the end on how is the scale of it. Is it exposure time is more than 15 minutes to 45 minutes? So this is the Acuity tool, and it will tally up at the end, stating how many staff that we are going to need and how can we divide the, the workload between them. Uh, during the start of the pandemic, during the conceptualization, the risk register assessment of receiving COVID-19, we were already predicting that we will be receiving patients who had disabilities, those that are for rehabilitation. Indeed, we did. We received them, and these are some of the, the diagnosis of these patients. We have traumatic brain injury, we have left above knee amputation, multiple sclerosis, stroke, transverse. These are just some of those patients that we received who are with disability. So that made like caring for COVID-19 patients more complex. Yet we've managed. Here are also some of the nursing diagnoses that we have seen and we have planned for or took into took into account during the whole COVID pandemic care. Our nursing our nursing care provision is not limited to what I've mentioned. It also involves interdisciplinary collaboration and referrals. Meaning if the patient needs to acquire physical therapy evaluation, other physicians evaluation, like for example neuro, we do the referrals, and our facility is providing them. So we also ensure that patients involved in the provision of safe environment of care, uh, we involve them in the treatment. We use effective therapeutic communication to cater for their preferences, as effective nursing process utilization of the ADPI. And with that, having that in mind, during the active COVID case phase of the patient, all of the things that I've mentioned before were really adhered to, like measuring measures to solve the COVID-19 signs and symptoms. May it be independent nursing action, dependent, collaborative, those actions, we all did them. Transmission prevention measures, providing patient education, all of those stuff. And when the patient recovered, meaning revealed negative result of PCR and is ready for rehabilitation, we did this. We continued the preventive measures for that patient not to have the infection. And we made the measures, we applied measures for optimal level of functioning, skincare and wound management, patient and family education, all of that stuff. FIM, as I've mentioned, the functional improvement measures for bowel and bladder. There are some patients who develop incontinence, and we bladder training, bowel training, and stuff like that. We're also there. One example of this is that this particular patient is during her time when she was admitted. She was a 60-year-old female who is independent, ambulatory. The known comorbidity is only to have diabetes mellitus. She was COVID PCR positive in admission and was admitted in the inpatient, and then stepped up to the COVID-19 ICU. She had pneumonia, RDS, cytokine storm, bilateral pneumothorax with tracheostomy, septic shock, history of septic shock, multi-organ failure, ventilated, NGT fed. She needed ECMO. And then she progressed, and when she revealed negative PCR, slowly weaned off transferred to a regular ICU, weaned off, and then transferred into the inpatient rehab unit. In the rehab unit, this patient was admitted. She had the effects of COVID-19, brought quadriparesis with mobility and self-care impairment. She was ambulatory when she came in, but she had quadriparesis. Functional assessment, bed rolling, modified independence. These are some of the carryover skills that we have provided here, provided this patient, particular patient, 24 hour service. She was then continent, became continent after the trainings, both bowel, bladder, although she was placed on diaper just for her convenience, on mechanical soft consistency food before she was on NGT. She improved a lot. Muscle power, bilateral hand function, improved bed and sitting balance and transfer techniques, improved performance and self-care. When she was discharged, she was walking. She was crying when she saw us because there is another set of nurses and other team who took care of her. So when she discharged, she went back to us and she was really crying and she was happy about the progress, about her success. So these are just some, but certainly not limited to our interventions. These are just the focus of care pertaining to the rehab program, as what I've mentioned. So the optimum lung expansion is there, making sure that the oxygen supply is there. Patient is having his full lung expansion so that the oxygenation is ensured. Mobility, as I've mentioned about the range of motion exercises, even while in COVID unit, the prevention of secondary complication, pressure injuries, and other related conditions. We also have interdisciplinary collaborations for psychology, dietitian referral. So we have our only lymphedema program and bariatric program. So these are just easy referrals that we are provided. We can provide. I mean, we have bladder training, the pain safety, collaborative approaches includes drug administration. These are just some goals, roles, and responsibilities are here. So these are just some of those notes that I took during that particular time, and the responsibilities that were required from the nurses. For the sake of time, I will just proceed. So how did we turn up? How did it resulted? How can we say that we did took our or render our part in flattening the curve? So this is the data that we have. Uh, its impact for the patient and the family that we served, we had a recovery percentage rate of 95.8. The total initial swab revealed positive was 311. These are just small in numbers in comparison to other hospitals, but the recovery rate and the way we is just worth noting. The total PCR test done in this facility was 3,085. ICU admission is just down to 1.6%. Mortality is just but 0.6%, 0.6%. Our contact tracing at this particular time, 4th of April, we still have pending interview of 6. I think by now it is finished. High-risk contacts, these were part of all of those contact tracings that we have. The impact into the organization is this. Percentage of COVID-19 staff who got infected, those that are with us in the front lines, is only 0.04%. Percent of COVID-19 who were competent, number of COVID-19 competent staff, we have 102, but we have only activated 72 of them, all volunteers. Percentage of staff who received the competency, all of them. We have still a backup that we never we never activated because those that are with us were enough at that particular time. But all of those backup or activated, they're all competent. It impacted as well the awareness of clinicals and non-clinicals about COVID-19 and uh, employee vaccination status for the time being. Uh, Clinical staff, we are up to 25% already who have it's different. I mean, these are just of the first doses. 25% of our population already had the first dose from the clinical staff. Non-clinical staff, 5.47%. Yeah, there is just the the registration part and the booking part. I think it is being worked out right now. But 23% of our total population already completed the immunization. And most of these people, these employees or staff, they are direct care providers. So this is very important as well. And the advocacy for the immunization part is an addition to reaching herd immunity. our result, our contribution in flattening the curve. The red will define our cumulative cases, the positives. The recoveries are in green. It's clearly stating there. And also the active cases as of the time being is flattened up to 8 as of the moment. So we made our share in flattening the curve in our own small way. This is a part of our dashboard for April 4, 2021. These are just but a sample of what our dashboard is looking. Okay. This model of care in this COVID-19 success in Sultan bin Abdulaziz Humanitarian City was also nominated and took part in the National Patient Safety Award here in Saudi Arabia and was one of the nominees for the award. So because of the success, it was also nominated, as I mentioned. Key points to ponder before I end my presentation. Pandemic will be over with our adherence to the IPC measures and our participation for the herd immunity. It will be over. But the threat of another pandemic is real and imminent. We have learned a lot from this situation. So coming from as a nurse leader, the longer the time of exposure is, the higher the likelihood of contracting the virus. We should plan the care and the movements or the activities efficiently. We utilize the necessary technology for this, the use of mobile system, even the use of phones to communicate, for, even for the patient and the staff on duty or to the family because they will be on isolation. The earliest time rehabilitation is considered, the higher the probability of improving to optimum level of functioning. Nursing care planning should always involve the concept of rehabilitation. It decreases impairments, patient length of stay, and the overall cost. Best, it promotes best patient experience. A patient involved in his care who had a positive patient experience will be more motivated to turn his disability into his ability. So this is just a tribute and acknowledgement to those that served with me. Every day is a realization. We walk and work amidst the presence of selfless and brave souls. Credits to our volunteers. And thank you. And with that, it's just a privilege and an honor for me to present it to you. I'm ready to accept or answer any questions that you may have. Thank you.
Thank you, Mr. Erik, for this wonderful session. Really, it was amazing for sharing with us your facility health coping with this nursing model. I have one question for you. The Prof. James is asking, could you share a little more of your journey during this time? What parts of your initiatives are due to adjusting existing process to accommodate COVID? And what parts of your recommendations are previously unknown gaps that will become insular post-COVID?
Our services were to answer the question, Dr. James. Our
Mhm.
services were mainly rehabilitation, but yet we are also catering for acute cases, but not that much. We have a surgical center for excellence as well. But during this particular time, the as rehabilitation is not um, the rate of occupancy during that particular time also was affected. Patients are more wary and they were quite uh, not confident, let's say, to be admitted. So our census really dropped, and that paved the way for us to allocate the right resources. Um, we were still ready to receive them. There are still units that were functioning. We just isolated one building, one actually four units. It's a building and another unit too, because one building is one unit, three units. Isolated them, meaning not physically yet. We have isolated all of the entrance and exit. We have utilized unilateral direction, one entrance, the other exit is another one. So we have for service wise, the services that we provide as a rehabilitation facility still was ongoing at that particular time. Yet we have to allocate some staff, some resources because we were having less of what we previously were catering to allocate them to the COVID-19 program. Uh, to answer as well, what parts of our
Mhm.
accommodations are previously unknown gaps, can I ha- have a clear question, doctor, if you can
Sure.
rephrase?
Sure.
Yes,
I
doctor.
think we're learning because of the speed that we have to process folks, that there's support processes or things that caregivers need that aren't there when they need it, delaying the time and to deliver. And I think later on in the conference, people are going to talk about some lean methodologies. And so, there's a thoroughness, speed, and closure aspect of lean. And this COVID has increased the need for our systems to be flexible. And in some places, we're discovering that the processes to support the clinicians were either
Mm.
not there or were inadequate. And now because of the crisis, all of a sudden it's getting attention from leadership to be solved. And I didn't know if
I think I'm agreeing to you, doctor. Totally, I'm agreeing to you. One example of this is that our intersystem, our HIS, or our health information system, is running on modules. And if we are doing documentation for rehabilitation, we have leaned those documentation out. As I've mentioned in my presentation about FEAM scoring, we previously were doing that because we are to assess and reassess every week for the patient. But at this particular time, rehabilitation was also taken into account. Yet the documentation part of the rehabilitation were taken or were just as part of the module, just to make sure that we give the appropriate time for the real documentation needed for COVID-19 care. So this is just one example of it.
thank you.
If I answer your question.
Yes.
Thank you, Mr. Eric, and thank you, Prof. James. Actually, we have to move fast.
Sure.
Now, our next speaker will be Ms.